Welcome back to Corium. I'm Brian Gilberti, and today we're joined by Dr. Anne Levine, a former chief resident here and now one of our industrious and brilliant simulation fellows. And together we're going to do a quick episode on capacity assessment. Anne, thanks for being on the podcast.
I'm excited to be here. Thanks for having me.
Now, capacity comes up more often than we realize, and knowing how to approach it confidently is key. So let's start with the basics, Anne. How do we define capacity, and why is it so crucial in our day-to-day practice in the ED?
Absolutely. I agree. I think this topic is so important in emergency medicine because this might be a problem that we face on a daily basis. As a first-year attending, the challenging resuscitations and difficult intubations don't keep me up at night quite like a challenging capacity assessment. This is the art of medicine. Capacity assessment is important because there are patient safety and legal considerations. It's a balance between doing no harm and maintaining the ethical principle of patient autonomy. This is the whole theory behind decision-making capacity, that we have to honor and respect a patient's autonomy, which is their ability to shape their lives in accordance with their beliefs. And people have the right to be free from unwanted bodily intrusion. When a patient lacks capacity, then we as physicians have a duty of beneficence or acting in a patient's best interest. However, this can be a really intimidating decision to make. And if a patient is determined to lack capacity, then we're effectively restricting their autonomy.
Perfect. And that really highlights how nuanced these decisions can be. So let's make it a bit more concrete for everybody. And if you could, walk us through some real-world situations where we'd need to assess capacity in the emergency department.
Yeah, of course. So I think I'd just like to mention first that capacity, it's a snapshot in time. It's both time and decision dependent. It's important to remember that capacity can change with the circumstance. For example, a patient may be able to consent to a placement of a Foley catheter or peripheral IV, but they lack capacity to consent to a more invasive procedure like an XLAP. The time aspect is also important because individuals may have impaired capacity from a reversible condition at one point and may have full decisional capacity when that condition has resolved. I'm going to go through a couple examples that we see frequently in the ED. This one might sound familiar. An intoxicated patient who presents with head trauma after a presumed fall. On exam, they're slurring their words, they have facial abrasions, and they have facial bruising. You don't know the mechanism of injury, and clearly their physical exam is not reliable. You order a head CT to evaluate for traumatic injuries, but the patient refuses a scan. A second example, an older patient presents with fever and flank pain. On exam, they aren't super toxic appearing, but they are tachycardic, they're febrile, and they have a white count. And their urine's infected. You want to admit this patient for urosepsis, but they decline admission as they have a dog at home that they have to care for. And the last example I'll give, let's say a patient presents from their primary care clinic with poorly controlled diabetes for evaluation of a gangrenous foot. You consult surgery who recommends an amputation. The patient declines surgery, but they are agreeable to IV antibiotics.
And spot-on examples, things we see all the time, but may not always pause to formally assess. And once we recognize that a capacity assessment is needed, what framework should we use, Anne? And what are the essential components we need to evaluate?
There are 4 key criteria that a patient must meet. They include understanding, appreciation, reasoning, and choice. Let's first start with understanding. Can the patient understand their medical situation, the prognosis, the recommended care, as well as the alternatives and the risks and benefits of these options? Are they able to process and retain new information to teach back to you what you've taught them? Some questions you might ask the patient are, what are the options for your situation? What is your understanding of the benefits of treatment? And what are the odds that this treatment will work for you? What are the risks of the treatment? What is your understanding of what will happen if nothing is done? The second component is appreciation. The patient must be able to appreciate the medical illness and consequences of treatment or absence of treatment and how it relates to them and affects them personally. Can the patient appreciate the impact of their choice, and are those decisions consistent with the patient's values and goals? Some questions you might ask are, tell me what you really believe about your medical condition, or why do you think this treatment has been recommended? And what do you think will actually happen to you if you accept the treatment or if you don't accept it? The third component of capacity is reasoning. Can the patient explain their decision-making in a way that the treating physician finds reasonable? Can they demonstrate logic and rationality of their choice? We may have differing values from our patients, but that doesn't make their choice wrong. It isn't about the patient's decision. It's more about how they arrive at that decision. Some questions you may ask are, what factors or issues are most important to you in deciding about your treatment? What are you thinking about as you consider this decision, and how did you come to this conclusion? The fourth component of capacity is the ability to express a choice and communicate. Can the patient communicate with you? Are they speaking, pointing, or writing? Questions you might ask are, you've been given a lot of information about your condition. Have you decided what medical option is best for you right now? Or we have discussed several choices. What do you want to do?
Very good. And it's clear that thorough capacity assessment goes beyond a quick conversation. It requires structure and attention to detail. But we all know that real-life ED dynamics can really complicate these things. So what are some of the biggest hurdles clinicians face when doing these assessments, and how can we manage them effectively?
Yeah, so we face a lot of challenges in the emergency department. A few challenges related to capacity assessment include time pressure. As we know, the ER can pile up, and a lengthy capacity assessment or discussion of AMA may take us away from caring for other patients. Another common challenge are communication barriers. We treat a diverse patient population, and patients may have a neurocognitive disorder, underlying psychiatric disorder, speak a different language, or have different cultural values than we do. And the third challenge are ethical dilemmas. The patient may demonstrate reasoning or logic, but you don't agree with their choice, or it doesn't align with your values. You might also encounter a patient with a psychiatric disorder and you're unsure of their baseline. Some strategies for these challenges. First, for time pressure. This one's really hard. Obviously, in the ED, time is one of the most valuable commodities. It can be easy to underestimate the significance of a patient leaving against medical advice, but we caution against this because we know patients who leave AMA have a higher 30-day mortality and 30-day readmission rate. And some strategies for communication barriers include interpretation services. If there's a language barrier, absolutely bring patients into a more quiet environment. We know the ED can be loud and chaotic. Involve family if that's okay with the patient. And of course, use simple language and avoid medical jargon. And lastly, for ethical dilemmas, there are many assessment tools available. There's no one best test. A commonly used assessment tool is the Aid to Capacity Evaluation, or ACE, which is a formal, directed clinical interview that objectively assesses the 4 elements of capacity that we previously discussed. It's available online and it's been validated in large studies. But I would say, when in doubt, reach out to psychiatry. They're really the experts of capacity assessment and, of course, risk management in your department if needed.
Excellent, Anne. And you've touched on some of the great practical strategies there. Now, before we wrap up, I think it's important that we address the legal and ethical side of this. So what should providers keep in mind when it comes to documentation and protecting both the patient's rights and ourselves?
Well, definitely reach out to your department leadership. Each state has their own legislation regarding capacity assessment. Patients with capacity have the right to refuse treatment, but as the physician, we must inform the patient of the consequences of refusal of treatment. And let's not forget, there's also a legal risk to emergency physicians from forced treatment. There are some best practices that have been published in Annals of Emergency Medicine, and I would recommend that we clearly document our capacity assessment, which again includes understanding, appreciation, reasoning, and choice, as well as documenting the delivery of information, including the proposed interventions and risks of refusal, delivery of information including alternatives to the proposed intervention, the patient's understanding of risk and voluntary decision, discharge instructions, including follow-up care and prescriptions if applicable, and an invitation to return for care at any time. Make sure you include witnesses to the conversation as well. And again, if in doubt about your capacity assessment, reach out to psychiatry and your risk management team.
And an incredibly valuable discussion, and capacity assessment is one of those skills that blends medical knowledge, ethics, and communication, something we're called to navigate every day in the ED. So thanks so much for breaking it down and giving us these practical tools. And again, thanks for being back in the studio with us.
Thanks for having me.